fact check, so I apologize for
So don't correct her.
Don't correct her. Spelling typos in there, and just word typos. I was embarrassed when I saw it. Again, like Sally said, I was a PT to start with. I went back to school to be a PA. I was in private practice for 10 years in primary care, and then joined the world of orthopedics, kind of. I'm in an orthopedic practice, Oklahoma Sport Orthopedic Institute, but I run a bone health clinic for them. So I do osteoporosis within, which is really a primary care thing, or an internal medicine thing, but I do it within an orthopedic setting, which is pretty common these days. It's primarily where osteoporosis is treated. It's becoming more and more popular to have it treated in an orthopedic setting. I also do some administrative stuff for Oklahoma Sport Orthopedic Institute. I'm now the Director of Clinical Operations for them. So when we get done, if you have any questions about anything related to primary care, private practice, administrative medicine, I'd be happy to answer anything if I can. I'd be happy to share whatever I can with y'all. So let's get started. Today we're going to talk about the super awesome topic of osteoporosis. Oh, my disclosures are I do speak for both Eli Lilly and for Radius Health. You'll see later they are the makers of the two drugs that I use primarily. And so I speak not necessarily on the topics of their drugs, because the first drug, Forteo, which we're going to talk about, has been around for 15 years. So people know how to use it. It's not about the drug. It's about how to run and establish a bone health clinic and how to get people in for treatment and to understand the world of osteoporosis. So to understand why we lose bone with osteoporosis, we need to understand how we make it. And it's a cyclical process. You can see it just like many things and many systems in the body. This is a cyclical process. And so we have a team of cells working in concert. And we call that team of cells a bone remodeling unit, or a BRU. There's a million of those at any given time working to make sure that your skeleton is regenerated, which it does so every 10 years. And so we see what we want is bone homeostasis, which is that very top rectangle up there. And when we have a fatigued or an area that is stressed or degenerative, the bone signals, we get a signaling process, and we have an osteoclastic response. An osteoclastic response, which is the little red cells up there, come in, they get rid of the older and fatigued bone, which, bless you, which leaves us a little crater there in the bone, and those osteoclasts actually terminally differentiate into an osteoblastic function, and they repair that bone, and we ultimately end up with a neutral bone balance, which is that top rectangle, and we have what we call a homeostasis of bone. So that's how it should work when everything's working right. Unfortunately, that sometimes doesn't happen. And so osteoporosis is a skeletal disorder characterized by compromised bone strength, which puts you at an increased risk of fracture. Notice it didn't say that you had less bone. It didn't say that it was a decrease just in bone density. It's actually bone strength that matters, because fracture is a result of a strength of bone issue, not a bone density issue. And so as we talk about osteoporosis and you talk about all these screening tests you have to do in preventative medicine, which is like a DEXA scan, we get really honed in on that bone density, but really it's the strength that matters. Bone density plus bone quality equal bone strength, and ultimately bone strength is what matters. Osteoporosis is the most common type of bone disease. And you can see the difference between, that's trabecular bone or cancellous bone in those pictures, and you can kind of see the difference there between normal bone and osteoporotic bone. Symptoms. So how do people know they have osteoporosis? They don't. They have no idea they have it until they fall, they trip over their dog, or they trip over their flip-flop, or their flip-flop catches, and Sally's like shaking her head up there, because we were in orthopedics.
That door jam between the garage and the house.
Flip-flop catches, down you go, arm out. First fracture is here or here. Every time we call that the flip-flop fracture, it should have an ICD-10 code. Because every time it is the flip-flop fracture. And this fracture right here in your 52-year-old newly postmenopausal female, just make her 30% more likely to fracture her hip in the next 5 years. Because guess what? This was indicative of what her bone looks like. Adults should not fracture bone when they fall from standing height. You can fracture when you fall off a ladder, when you jump off a roof, when you fall off a horse. You should not fracture when you fall from standing height. How many of you guys have taken a tumble here in the last year? Probably at some point, right? You hit the ground. Did you break anything? No, you didn't. But when you're 52 years old and you take that tumble and you break something, you're going to say, ooh, but I fell on the tile. Ooh, but I fell on a dog, or I hit the armoire on the way down, or I did something that caused that fracture. No, you didn't. Your bone looked like crap. That's why. It had nothing to do with the fall or what you landed on. It's because your bone is not of good strength. And so adults should not break bones when they fall from standing height. And if there's one thing you remember when you walk out of here today, it needs to be that. Because when you get out in clinical practice and it happens, and somebody says, oh, but it was the concrete, and in your mind you go, yeah, but it was concrete. No. You tripped and fallen out here on the sidewalk, you didn't break anything, neither should they. So don't let those fractures pass you by. Those fractures are crystal balls. They're telling us what's coming down the pike, and if we paid attention to them, we could reduce that rate of hip fracture that we're seeing. And so, who is at risk for osteoporosis? Usually it's menopause in women. Yes?
Did you say that, like, if you were to break your arm, that represents the rest of your bone strength?
Can be. It is, yes, it is indicative of a potential problem. So it's what we call a red flag. Does it always mean there's a problem? No, but it should raise a red flag and it should cause us to look. Regardless of, even if all of these risk factors don't exist, at OSOI, if you fall and you break your arm from a fall from standing height and you're over the age of 45, which you'll see doesn't meet any of the screening qualities, those are our screening factors at OSOI, you'll get a DEXA scan and you'll get an appointment with me because that fracture is indicative of a bigger problem. And we do not want to see you back with a hip fracture. It is our due diligence, it's our ethical stand that we need to do something to prevent that from happening again. So it's a crystal ball. It should make you look. Even if you don't do anything, it should actually be an educational moment, it should be a discussion point, and it should be a time in which you screen. So risk factors for who should we be looking at for osteoporosis? Since there are no symptoms, nobody walks around saying, hey, I think I have osteoporosis, or I'm going to go see my primary care doctor because I've got this osteoporosis coming on. Nobody does that, so we don't treat it. So we have to really be thinking about potentially what the risk factors are, so we make sure we hone in on that population. Menopause in women and low testosterone in men. Hypogonadal men are a huge group that we miss, and those are really young fractures. I've got 3 fractures, hip fractures, no, 2 hip and a pelvis fracture right now in men in their 40s, and they're all hypogonadic. And so they have not had testosterone or enough testosterone for quite a few years, and their bone is terrible. And so big time fractures, and they don't heal real well either. So really important for those 2 groups. Anybody that's confined to a bed or a wheelchair or just plays video games all day long, that inactive lifestyle is a terrible thing and terrible for bones. So really somebody else to look at there. Vitamin D deficiency, which we're going to talk about more in depth here in a little while, and somebody with a low calcium diet. Anybody with GI surgery that's so popular right now. We have the gastric sleeve, the banding, the bypass, whatever else they do now, colon resections. Anybody where their GI tract has been shortened or we've taken some of it out, absorption is an issue, they're eating less meals, nutrition is a problem, all of those things are increase your risk for osteoporosis. Hyperparathyroidism, hypogonadism we already talked about, and other endocrine disorders. Hyperparathyroidism is not a real common problem, but you will see it. At some point you will see it. When a young person has a pretty massive fracture that's out of line with their age and no other risk factors, maybe your 30-year-old that breaks their femur or their arm, and it's a pretty traumatic fracture for what actually happened. They just tripped over the dog and they landed on the carpet. And boy, did they have a terrible fracture, or multiple fractures. That should raise your red flag for hyperparathyroidism. Chronic rheumatoid arthritis, autoimmune disorders in general. Partly it's the autoimmune disorder and partly it's the medications we use to treat them. Chronic kidney disease, eating disorders because of absorption, medications, anti-seizure medication is a big one, especially the old ones, Dilantin and Depakote, big problem there with osteoporosis and bone after long-term use of those. Steroid use, most people are familiar with steroids and their issues with bone. It's 3 months, it's not the steroid pack, it's not an injection, it's not a joint injection that does it. It's oral steroids at doses at 5 milligrams or greater for 3 months or longer. So a steroid pack is not going to do it. It's long, high-dose steroids. And it's not everybody who takes them either. It's just a risk factor. Family history of osteoporosis, a primary relative with a hip fracture makes the next generation almost twice as likely to break their hips as they would be otherwise. So mom or dad or a sibling with a hip fracture, we call it fragility fracture. The term for that fall from standing height that breaks the bone is fragility fracture. It means your bones are fragile. So if mom or dad or sibling has had a fragility fracture, their risk is much higher as well. Anybody with a low BMI, smoking, alcohol, and anybody who's been treated for breast or prostate cancer long term. So those are both because of the hormone suppressing drugs. So tamoxifen, for example, with women that have had breast cancer, suppresses estrogen and hormones, and so we have a huge issue there, and we're using it longer than tamoxifen used to be a 3-year thing, then it was a 5-year thing. Then we moved it to, well, maybe 10 years, and now we're talking about maybe forever with some people, which is great because cancer will kill you, but also we have to be aware of the fact that these people will have fragile bones and potentially do something to help them. Prostate cancer, same thing. Anytime we use any of the injectables that suppress testosterone, huge risk there because we make them hypogonadal. Why do we need to treat it? Because it's really common and people break all the time, and it is a very expensive and debilitating problem. It doesn't really kill you. It does. I mean, everybody knows there's a hip fracture statistic, and that, you know, within 6 months, a percentage of people will die from a hip fracture, but there's never been a death certificate that actually had osteoporosis as the cause of death. And so I hate using the death statistic because really, it doesn't kill you, it just makes your life miserable, like miserable. If you break a hip and then a pelvis and then something else, now you can't live alone, and if you're 75 years old and all you want to do in life is live at home, and now we're going to put you in assisted living, but then you break something else, so now I put you in a nursing home, now you're really pissed off about life, and you really wish you weren't alive, and you wish the hip fracture would have killed you 9 months ago. But it doesn't kill you. It makes you miserable. And so it has a greater morbidity statistic than a mortality statistic. It is the #1 cause of nursing home admission in the United States. So that #1, so heart attack, stroke, all those really big things. People think, oh, I bet that's the #1 cause of nursing home admission. No, too many people die from that. A lot of people get those things, but a bigger percentage of them die. All of the hip fractures, all of the spine fractures, the pelvis fractures, they end up in the nursing home and in assisted living centers. So they are the #1 cause of those admissions every year. And they always lose something. Those patients always lose something they never get back. Something that relates to their independence. It might be driving, it might be living alone, walking, anything important. Again, the death statistic of 25%. Quarter of patients will die within a year of breaking a hip. Fracture itself is a sentinel event. We've kind of talked about this. It is the crystal ball. So it's not just a forearm fracture. It's not just a spine fracture. It's not just a hip fracture. It is telling you what's coming down the pike. It is a sentinel event and needs to be treated as such. Who should we screen? Who should we test? So if they're not fractured, anybody who breaks a bone over the age of 50, especially from a fall, needs to be screened. I don't care if they don't meet any of the other indications for testing. If they have fractured, they need to be screened. But say they haven't fractured. Well, if you are menopausal, then you need to be screened. Some women are menopausal at the age of 30 because we took out their ovaries and we took out their uterus and we did a oophorectomy and a hysterectomy, and we have not given them estrogen therapy. It happens. It happened a lot about 20 years ago. So we created a lot of hormone deficient women in their 30s about 20 years ago. And it still happens. So if you have a patient like that, they are menopausal, even if they're 30, and they should be getting DEXA scans. Men over the age of 70. So even if a man hits 70, they should have a screening DEXA scan. If they have any of the previous risk factors we've talked about, they could be screened earlier. Sometimes we do a DEXA scan because we're treating them. If we're treating them with some type of therapy or even exercise or vitamin D or nutritionally, we should also be screening them. And there are PQRS, MIPS, and HEDIS measures, which I know don't mean a lot to you right now, but those are all markers for quality care with Medicare and different insurance companies. And right now their marker is men and women over the age of 50 with a fracture. So if they break, they need to have a DEXA scan on file, or you get a little checkbox next to your name. How do we diagnose osteoporosis? So a fragility fracture of the forearm, the distal 1/3 radius, that's the forearm, the spine, so a compression fracture of the spine, or the hip. So those 3 fractures are, when they occur from a fall from standing height, are diagnostic of osteoporosis with no other test. You don't need a DEXA scan, you don't need a surgeon to go in there and tell you. Those 3 fractures tell you what you need to know. It is diagnostic of osteoporosis. A bone densitometry can diagnose it, and that we're going to look at that a little bit later. It's called a DEXA scan, and it measures the density of bone at least one location. We try to get 3 or 4 locations. Sometimes a surgeon, when they are in, especially an orthopedic surgeon, when they are in doing a surgery, if that bone looks terrible or doesn't look right, they will get a bone biopsy, and they can also tell us, that can tell us if the bone is osteoporotic or not. A bone densitometry is, other than fracture, is the easiest way to diagnose osteoporosis. A bone densometer is the recognized way by the National Osteoporosis Foundation, by the International Society of Clinical Densitometry. It is not the best test in the world, I'm going to be honest. It is truly not the best test in the world. It's just all we have. And so we've worked really hard to make it a statistically good test. Still not great though, still not great. Its benefits are it has a very low radiation exposure, very low. In fact, if you're about 2 feet away from that machine, there is 0 radiation exposure. It's extremely low from a sievert perspective. We usually scan the hips, both hips, the spine, and the distal radius. We only do the distal radius if for some reason we can't do one of the other sites. That's kind of our extra spot. But we always try to get as many sites as we can. We also, on a DEXA machine, you will sometimes hear of them doing other things, like a total body composition. So it measures densometry not just of the bone, but also of muscle and other tissue. And so the DEXA is actually the gold standard for how to measure total body fat and lean muscle mass and things like that. We can actually get percentages of body fat and muscle mass. We do it in athletes a lot. We do it for rehab sometimes to see if somebody is ready to get back into playing a sport, for instance. If their muscle mass is not equal in both legs, they're probably not ready to get back. And so there are other things that DEXA is used for. We can scan pediatric patients with it to look for growth issues, also to look for bone densometry issues and for body composition issues. And we like to use it for peds because it's very low radiation. We also can scan people that have a total joint. We call it an orthopedic hip. So if they have a total hip replacement in, we can scan around the hip joint and see what that bone looks like in all the little Gruen zones around the hip. And that is what a bone densometer looks like. The device at the end of the bed there is it holds the feet into internal rotation because we want to make sure that we get the best picture we can of the hips. And so we internally rotate them a little bit. And basically patients just lay on that bed and the arm on the top zooms over them and back and they're done. It is literally about the easiest test ever. Who should be tested is a judgment call. So you can do it based off screening, you can do it based off fracture, and depending on what group you follow, the NOF tells you to screen at one time. The U.S. Preventative Service Task Force, we call that the USPSTF, they tell us to screen at a different rate, and the American Academy of Family Physicians tells us also to screen at a different place. So really it's a clinical judgment call. So when all 4 groups don't agree on something, it means it's a clinical judgment call. If you think a patient needs to be screened because they have enough risk factors, screen them. That's really what it is. A DEXA report, when you get it back from a hospital or from a clinic or from a radiology center, should include certain things. Otherwise, it's not a good test. And many, many times that this is the case. It always should have the patient's demographics on it. It should always have the indications for the test. Were they estrogen deficient? Were they hypogonadal? Do they have a history of fracture? Are they on seizure medicine? It should include the manufacturer and the model of the equipment used. Because if you're comparing this test to another DEXA scan, if we're doing a comparison, it is difficult to compare from one model of DEXA to another model of DEXA. So it's important to make sure we know and it's reported what test or what type of machine the test was done on. And then we want to make sure we know what was scanned and what wasn't scanned. So if there wasn't a hip scan, if we only scanned one of the 2 hips, why wasn't the other one scanned? It's why didn't we scan the distal radius? Was there a history of fracture there? If there's a fracture history, we can't scan it. So it's important to know why, what areas were scanned and why. There should be a bone mineral density. For each site, BMD stands for bone mineral density. There should be a bone mineral density for each site that we do, with a corresponding T-score and Z-score, which we'll talk about in a minute. It should include the WHO, the World Health Organization, criteria for diagnosis of osteoporosis, normal, and osteopenia. It should include a FRQS score, which we're going to talk about in a little bit. That is a predictor of fracture. and it should tell you when they recommend the next test to be. A bone density test is going to give us a T-score. A T-score tells you how much the bone mineral density is higher or lower than that of a healthy 30-year-old adult. So we're always comparing to a young adult normal. We don't compare bone to someone their own age after menopause, because the increase of osteoporosis with age, I don't want to compare somebody that has osteoporosis with somebody else who has osteoporosis and say, well, they're the same, so it's normal. That doesn't make sense. If they're both going to break, that doesn't make sense. The goal here is to find out where the normal is, what normal should be, which is about a 30-year-old adult, and compare everybody else to that normal so that we know. People ask me all the time, well, yeah, but I'm 65, so is this normal for 65? No. We screen people all the time getting ready to have hip replacement surgery or knee replacement surgery. They might be 85 years old, and their bone is better than mine. It is not normal with age to have bone loss. It's common, and it happens a lot, but it's not normal. I see tons of patients every single day that are much older than I am, 50s, 60s, 70s, 80s, and they have tons better bone than I do. And so it's important to remember that when patients say, yes, but this should happen, I'm 65, this should happen, I'm 75, this should happen, I'm 85. No, it shouldn't. It is not necessarily. Osteoporosis is not a normal process of aging. You can lose a little bone and not get to osteoporosis and be fine. So important to remember that we're not comparing to someone their own age after menopause. And so we can see the screening here. Everything's based off the bell curve, where 0 is normal here. You will have patients who have positive numbers. Their bone is better than normal. You can have patients whose bone is worse than normal. So when they start getting into the negatives, once you are 1 standard deviation below the mean, that's when we start to say you have osteopenia. Osteopenia is a fancy word to mean you have a little bit of bone loss. It's not crazy, we're not excited about it, it's just a little bit. So we're going to keep an eye on you. And you can be osteopenic all the way to minus 2.5. Minus 2.5 is the cutoff point for osteoporosis. That's at minus 2.5, now we say, okay, now you have osteoporosis. And the reason for those 2 cutoff points is not random. We didn't just decide one day that these were going to be the cutoff points because it looked like a good spot to be. They're based off fracture risk. So at minus 1, at 1 standard deviation below the mean, the fracture risk starts to increase. It just barely, ever so slightly increases. But when you get to minus 2.5, fracture risk skyrockets. So you will hear words like mild osteopenia, severe osteopenia, but you should never hear words that say things like severe osteoporosis or mild osteoporosis. Because once your fracture risk is as high as it can be, there's no difference between mild and severe. High is high. If you're going to break your hip when you fall, it doesn't really matter if your score was minus 2.6 or minus 3.6 because fracture is a fracture. Does that make sense? And so it is not, we don't ever use those qualifiers when we get into osteoporosis. And you'll have people that will be as bad as minus 4 or even minus 5. Once we get down to minus 5, it's just pretty bad and it's not a great test anymore. Yes?
Is that good enough to make a diagnosis?
Yes, so this is one of the criteria for diagnosis, is a minus 2.5 or below for osteoporosis. A DEXA will also report a Z-score, Z is in zebra. A Z-score is an age-matched score. You're only using this in younger adults, or somebody who is not postmenopausal or not hypogonadal if they're male, or if they're a child, you'll use a Z-score. We don't use these in postmenopausal or older women because, like I said, we're not comparing to normal. A Z-score, the cutoff points are a little bit different. We use minus 2 as a Z-score. It's not a minus 1 and a minus 2.5. The Z-score cutoff is a minus 2. And so if this was a child and we were screening them and we got a Z-score back, that was a minus 1.5, we would say that their Z-score is still consistent with bone for age and gender. It's age matched for gender, and it's within what we would expect to be normal. If it was minus 2.5, we would say their bone is not consistent for age and gender, and it should be evaluated further. Okay? So it's not, we don't make a diagnosis with children or young adults. We say it's either we need to follow up on it or we don't. We don't call it osteoporosis right off the bat. Good gravy. I'm so sorry, I'm thinking. Okay. Silence that here. Turn the buzzer off, I think I'm being tased. Let's see. Routinely, we do not do young, well, historically, and if you read up on DEXA, they'll say we don't routinely do DEXAs on young people. I wouldn't entirely say that's true anymore. We're starting to use it more and more as an earlier screening tool. It's not something that has trickled down yet to the textbooks and to your tests. And so it is, but it is, we are using it more and more, especially with kids, because it is such a low radiation tool. When you get the DEXA report back, always ask for pictures, because invariably the test was not done well, or whoever read the test did not adjust the zones that they're looking for, and make sure that the scores are reported with the corresponding image. So I get a lot of DEXA scans back that when I look at them, if you look at it and say, gosh, that doesn't make any sense at all, this test makes no sense to me, these numbers make no sense, ask for the pictures. Because if it doesn't make sense, there's probably a reason why. And so this is what it should look like, where we have a lumbar spine picture here, and we can see we do lumbar spine L1 through 4, and that we never use one vertebral body as a diagnostic tool, but we get a score for each lumbar vertebral body. But we never use one for diagnosis, we always use 2 or more. So we try to combine all 4, but every now and then you can't use one of them. Maybe there's been a compression fracture, maybe it's just really hypertrophic, there's been lots of degenerative change going on, and it's very hypertrophic. The femur there, you can see a lot of different boxes in there. The most important boxes are this rectangle right here, the big rectangle, that's over the femur neck. That's going to tell us what the femur neck score is, and you know when you fall and break your hip, that's generally where you break. Or when you break and then you fall, that's also where you break. There's also a hip fracture, a subtrochanteric hip fracture, that happens down in here. So we also look at a total hip score for that reason. So those scores in the hip come from a multitude of areas as well. So it's important to make sure that the bone looks like it's outlined, that the boxes are generally over the bone. You'd be amazed at some of the pictures I get back when I do my own DEXAs, but sometimes I get them from other locations, and the boxes won't even be over the bone. They'll be over soft tissue, they'll be over the pelvis somewhere, and nobody ever even looked at it. They just printed it off the machine and sent it. And so it's important to get the pictures. The pictures should also come with a reading of scores. And the scores should show not just a bone mineral density, which is that first column of BMD, but also that T score, and then a second column of the Z score. And you can see in this patient, when we're looking at that femur bone, there are lots of scores in the T score column. There are 2 scores that we use for diagnosis, and the other scores we use for surgical reasons. So the only 2 scores that we use in that box for diagnosis are the femur neck, so the top score that says neck left, and the bottom score that says total left. So that is the total femur score. And so you can see the total femur score is a minus 1.7, and the femur neck is a minus 2.7. And so this patient has a diagnosis of osteoporosis because they have one of those 2 scores that is beyond a minus 2.5 or beyond. So what we don't say is you have osteoporosis in your femur neck, but your total femur does not. We don't break it down. You either have it or you don't. You get, of all the scores we take out of your entire DEXA, the worst overall score becomes your diagnosis. And that's what we don't say you have osteopenia here, you have osteoporosis here, you have something else here. One score, the worst score is your diagnosis. This is the distal radius. So we look at the 1/3 distal radius. So the box that says radius 33%, and that is also the box that we look at for diagnosis, which is right here, and you can see that corresponds to minus 2.9. So this patient has osteoporosis. Oftentimes the forearm is maybe the only test we can do. Maybe they can't lie down, maybe both their hips have been replaced, and they've had compression fractures or spine surgery. Sometimes the forearm is the only one we can get. And very often it looks like this. Forearms are, when they're bad, they're bad. So you can see, we don't use for diagnosis, but we will use for surgery sometimes that ultradistal radius and the total radius scores. And if this patient were to fall and break, it would be really difficult to put hardware in them, as Sally can attest. She's been in those surgeries before.
Oh, butterbone.
They call it butterbone, yes. It's not really so much butter, though. I hate that term. It's more like marshmallow, but it doesn't rhyme, so orthopedic surgeons don't go with that. It's more like marshmallow, right? Yeah, it's butterbone. Nothing sticks. Screws don't stay in, makes the orthopedic surgeon mad. They call me and say fix it. Okay, so they don't like this bone. The FRQS score is an assessment tool. So it's going to try to predict your fracture risk. We only use a FRQS score when the patient is in that gray area of osteopenia. We don't use it for osteoporosis. We know what your risk factor of fracture is when you're osteoporosis. It's high. You're going to break. If you fall, the likelihood of fracture there is pretty high. But in osteopenia, man, you know, you need a crystal ball right there to decide what we need to do. Do we need to treat it? Do we not need to treat it? What do we need to do? And so we use the FRQS tool. So it's telling us what our 10-year fracture risk is. And so it's an estimate. Again, it's not perfect either. We use it to just guide treatment decisions. The postmenopausal women, 50 and older, anybody with osteopenia, and if they've not taken an osteoporosis medicine. If they've already taken an osteoporosis medicine, it kind of invalidates the test, or the FRQS score. So we generally don't use it in somebody who's already been treated. Anybody with a FRQS score of more than 3% at the hip or 20% at the spine is considered high risk and should be considered for treatment. Doesn't mean you're automatically, going to throw medicine at them, but you should consider it. Or if you're not going to use it, you should probably have a reason why you're not going to use it. The FRQS score looks like this, and it's calculated for you. There are apps that calculate it, and there are things, but it generally should come calculated for you on the DEXA scan, because the computer should also calculate it. When we're putting in risk factors, but it's important to look too, but this is something you should get a copy of when you're looking at a DEXA scan, so you can see what risk factors they put in. Because many times they will say there are no risk factors, and you know for a fact that this patient has had multitude of fractures in the past, or maybe you know that they smoke, but they put that there were no risk factors. And so it's important to know that the test and the scores were run correctly, and then it calculates them for you. So this patient has a 10-year risk of major osteoporotic fracture of 14.7% and a hip fracture risk of 2.1%. So we would not consider this person somebody we would want to treat when they had osteopenia, because their major risk is not more than 20% and their hip risk is not more than 3%. And when it gets reported, it often looks like this instead of the picture from the screen. This is what it looks like, but it should still give you your risk factors on there. So ultimately, how do we diagnose it? The bone density scan is part of that equation. A fracture history tells you what that bone quality is, and that's part of the equation. Sometimes an orthopedic surgeon is the one who tells me. Sometimes we do a bone density scan, and it's maybe osteopenic, but it don't look terrible. There's nothing screaming at me that says this is going to be bad bone. But the orthopedic surgeon gets in there and cuts the head of the femur off in order to put a total hip in and says, good Lord, there's no bone in here. This is crap. I don't care what Heather's test said. This bone is terrible. Right, Sally? It's happened. So that they get to tell. They have their hands on the bone. They have their eyes on the bone. They know bone better than anybody else. And so if they say it's bad, then they get to call a spade a spade. Okay? And so they also get to diagnose it. We need to always make sure that this osteoporosis has not occurred from some other metabolic disease before we treat it. Because if it is, we need to treat the underlying problem and not just throw medicine at it. The most common of those being a hyperparathyroid patient. And that is somebody who has fracturing multitude of times. Maybe they fractured 3 or 4 times real fast. Maybe you are their primary care, and you know they had a slightly elevated calcium on their last blood test, but it wasn't bad enough for you to really chase it down. You were just going to repeat it. But then they fell, and when they fell, they not only broke their forearm, but they also broke their humerus and their clavicle. Well, that's a little crazy for just a fall from standing height, right? So now you put 2 and 2 together and you think, elevated calcium, major fractures, we need to check for hyperparathyroidism. Hyperparathyroidism runs that bone metabolic rate on overdrive. And so we end up losing bone faster than we can fix it, okay? What's interesting is the medicines that we're going to talk about here in a little bit are PTH. They are parathyroid hormone. So it seems a little backwards because too much parathyroid hormone is going to drive you to lose bone. But when we give it to you in little tiny bits at a very, very specific amino acid chain, we actually differentially build it back. So it's a very interesting concept, but too much constantly is bad. and that's what hyperparathyroidism is. And most of the time, it requires surgery. They take out one of the little 4 pea-sized parathyroid glands behind your thyroid gland, and then you're good. And then we can treat you, and you're not going to lose more bone, and we can fix the bone loss that you had. Osteomalacia is a problem, vitamin D deficiency. And so you always want to check their vitamin D levels, which are a huge problem, huge problem. You want to check their ALK phos, sometimes they're bone-specific ALK phos. Paget's disease, you'll have a really awesome DEXA score, but a really bad bone history, and the surgeons look at it there and go, this bone is terrible. It's absolutely terrible. And I had one of these actually, a patient who was getting ready to have a total joint done. And we did, and it was a guy, and he had a couple fractures, so the surgeon sent him over, and we did a bone density scan, and his bone density scan was good. It was too good. He was a +4 on everything. I was like, man, you're good. That's too good. This doesn't make sense. And so we did a little more investigation, and sure enough, he had Paget's disease. And so we always want to make sure you can be too bad and you can be too good. Any extreme, not okay. Renal osteodystrophy, also a problem. That is from chronic kidney disease, which in Oklahoma, with our rate of diabetes around here, wow, that is a huge problem. So anybody who's had chronic kidney disease for a long period of time generally has poor bone quality as well. So we also can look at using bone turnover markers, both for diagnosis and for monitoring treatment. It is not something we do all the time right now, but it is up and coming, and over the next 10 years will be something we probably do a lot more. We have pros and cons to using them, just like any blood test out there. We don't have great norms for them right now. It's getting better, but we don't have great norms for them. And we don't always know what to do when they come back abnormal and we can't pin what the problem is on it. So we end up with an abnormal that we can't do anything about. We have markers of resorption. The one you're going to probably hear the most about there is CTX. That one is the most common one. It's the middle one on that list. And the markers of formation, which would be bone-specific alkaline phosphatase. If you ever see a child that has had a fracture or is having a lot of pain, and somebody runs liver function tests on them, or a CMP and gets liver functions, and their ALK phos is really high, oh my gosh, their ALK phos is really high, and then you break it down and you get an elevated bone-specific ALK phos, everybody freaks out again, and then you think, wait a minute, they're healing from their fracture. It's a bone formation marker. So we have to remember to not try to run that test when they're healing from a fracture or they're going through a growth spurt, because it will be a normal abnormal. P1NP, which is the last one in that bone marker or bone formation marker column, is one also that you will hear a lot more and more. P1NP is a marker that we are establishing pretty good norms for, and there are like 2 insurances that will pay now to have it done, so it's becoming 5% more common than it even was a year ago. When do we treat? Well, that's a great question, because we don't want to treat everybody. We don't want to throw medicine at somebody who doesn't need it, but we don't want to not treat somebody that does. And so what we need for treating osteoporosis really is a crystal ball. And so if we had that, life would be easier. Because I need to know if you're going to fracture again. If you're not going to fracture, I don't really need to treat you, because that's the point, right? Is to prevent fracture. But we don't always know, so we have to do the best due diligence we can and make the best decision we can and involve the patient in this discussion. Because if the patient says, yep, my mom broke and my dad broke and they both ended up in the nursing home and I don't want to do that, let's do this. Well, you have a very motivated patient who really wants to fix their bone. If there's a reason to and an indication, do it. Let's treat them. If you have somebody that's fighting you every step of the way, you give them as much education as you can, you talk to them as much as you can about it, but you don't fight them either. So this really is a judgment call. If they're osteoporotic, I would chase them out to the parking lot to treat. If they're osteopenic and they just have a lot of risk factors, you have to just keep talking to them about it. Every time they come in, are you sure? Here's your risk factors. Here's what we're doing. We're going to screen you. We're not going to let you go 5 years between your DEXA scans. We're going to make sure we do them every 1 to 2 years. Many patients that I see, they had one DEXA scan, they were osteopenic, and they hadn't had another one for 10 years, and they broke. And so it's because nobody ever followed back up with them again. So we just don't want to lose it. How do we treat osteoporosis? We always start out with nutritional and lifestyle. Physical activity, we try to modify lifestyle issues, and then when we have to, we go to medication. Vitamin D is a biggie. It is a huge problem all by itself. This is a bone problem that exists without osteoporosis. This is a bone quality problem. Vitamin D deficiency your body requires vitamin D to absorb calcium. So you can have the child who's drinking the most milk ever in the history of milk drinking children. And because they play video games all day and they don't go outside and they go to school and they don't go to recess, because I don't even know if they have recess anymore, and they never see the sun. And when they do see the sun, because they have really good parents, they're being sunblocked from the moment they go outside every 30 minutes with a new application of sunblock until they go back in the house, because they're really good parents, right? And so now that child has never had any sunlight. If they don't have any sunlight, they can't absorb vitamin D. If they can't absorb vitamin D, they're not going to absorb their calcium. And then what's going to happen? They're going to trip over the stuffed animal on the floor and break their humerus. And then we're going to try to go put a pin in it, and we can't put a pin in it because the bone is so soft. Am I lying, Sally? I'm not lying, am I? Right? Preach it, right? And then the surgeons call me and say, this 5-year-old has osteoporosis. I'm like, no, they don't. And they say, just check their vitamin D. And I'm like, I don't do blood work, I'm an orthopedic surgeon. All right, send them to me, right? And so you check their vitamin D, and it should be, well, by lab normal test, it should be 30. For bone, we really want it to be 40 or 50. But this kid has a vitamin D of 5 or 4 or 2, or sometimes it's not detectable. It happens all the time. So this is a huge and growing problem from a number of reasons. One, because we're just an inside generation. We're raising inside kids, and because we're really good parents and we sunblock our children. And that has also created a little bit of a problem. It's fixed one problem. The whole skin cancer thing is helping. But you know, I'm not here to talk about skin cancer. I'm here to talk about bone, right? So it's bad for bone. We do need some sun, or we need to replace the vitamin D. We need to do one or the other. And vitamin D is not nutritional. It's not something that we get generally in our food sources. We replace it a little bit here and there. There's a little bit in milk, and there's a little bit here and there, but it is primarily the sun vitamin. And so if we're not getting sun from another source, we have to replace it and supplement it. So many times kids that have fractures, if you have a kid that, you know, they break their arm, but it's not a bad break, they went to the urgent care, they threw a splint on it, healed fine, they never ended up in an orthopedic office, and you're the pediatrician or you're the primary care PA, and you know what, 6 months later, they have a little ankle fracture, a little foot fracture. It's not a bad one. Again, they go to urgent care and it's another one, but now it's number 2 in 6 months. Ding, ding, ding. Let's start looking at that bone, because that's what makes your marshmallow bone right there. And if your bone's a marshmallow and you fall on it and it's bendy, the more you bend something, it's physics, it's going to break. And so we want that bone to be really hard. We don't want it to be squishy like a marshmallow. So really important to make sure we're checking vitamin D. Kids don't even get vitamin D riding in cars anymore. I used to get sunburned on the way to grandma's house on the right side of my face, right? We tint car windows now. We tint your home windows. They have UV blocker in them. We tint windows in this building. We don't let UV pass anymore. There is new sunblock out that allows, it says it allows vitamin D to penetrate. It's about $60 for a bottle about that big. And I contemplated it for my kids, but then I decided replacing their vitamin D was cheaper than buying sunblock. And we don't even know if it works, but it is a thing, and you will see that more and more is because vitamin D is such an issue. So when you see repetitive fracture in children or an adult, or the patient is osteopenic, and you think, what can I do to help their bone? You can make sure that their vitamin D is good. Sometimes it's genetic, sometimes it's not lack of sun. There are some people we could stick them outside naked for 8 hours and they wouldn't get any. They just genetically do not have the cells that are absorbing it and allowing them to use it. And so we have to replace it in them. I have people that work outside for a living and their vitamin D is low. So you can't always tell by looking or by what their job is. You can't tell by somebody who's tan or not tan. You can't tell by looking. So you always have to check. I think I already talked through that one. How much should you take? Every time we talk about it and every time I make a slide, the what you can take as considered safe has been increased again. They recently did increase it to 4,000 units, even not being checked. So even if you've never had your vitamin D checked, they will tell you that it's safe to take 4,000 units a day. Vitamin D is a fat-soluble vitamin, so you can take too much. It's hard, it's really hard to take too much, but it is possible, especially since Costco started selling 10,000 units, or little gel caps, which were designed to be taken once a week, but nobody reads labels anymore, so everybody's taking it once a day, twice a day, 3 a day. I have people that come in, they're taking 150,000 units a week, and they're still not too much, a lot of them. So you can get too much, it's just really hard. So sunlight, food, little bit in food. Man, you'd have to eat a lot of those foods to get it, but a little bit. Supplements can be in the form of vitamin D2 or D3. It generally doesn't matter for bone health. Most of what's over the counter is D3. Ironically, most of what is prescription is D2. Most of the time, your body can convert them back and forth. There is the rare occasion that they can't, and I will actually supplement both, D2 and D3. Calcium, the important thing to remember about calcium is not to listen to your mother or your grandmother tell you about calcium, okay? Because they're all going to tell you to take a whole bunch of calcium and it's going to fix your bones, because that's what we told those generations to do. And then they all broke their hips because it didn't work, okay? So we spent a long time telling patients to take calcium because we thought it was the right thing to do, and we were wrong. And we've changed the public health communication and the public health education a lot over the last 5 to 8 years regarding calcium, but there is still, it's still ingrained. It is absolutely ingrained. Even though patients have been told, or somebody, I have cardiologists that tell their patients all the time, don't take your calcium because it's hardening your arteries, and yet they break a bone, the first thing they do is go get their calcium again, because they just can't shake it, okay? They just can't shake that. Calcium isn't going to fix your bones. Most of us get plenty of calcium, and as it turns out, lack of calcium was not the problem with osteoporosis to begin with. And extra calcium isn't something we just excrete real easily through the kidneys. It turns out when we get too much calcium, we're going to lay it down in all the places we don't want it. Like in the little arteries around your heart, those little arterioles in the kidneys, in your brain. We don't want it there, but that's what we're doing. And so we want to make sure we're not getting too much calcium. And not everybody needs a supplement. It's a really easy thing to say, oh, just take a calcium supplement. But you can get too much, again, so it's important to take a look at the diet. If they can tell you 4 dairy things that they eat in a day, plus 2 green vegetables, they're getting plenty of calcium. We put calcium in everything. From a dietary supplement standpoint, we put it in breads and cereals and pastas. If it came out of a box, it probably has calcium in it. We use it as a preservative in the United States. Way back in the 80s, when all the parents wanted to feed their children preservative-free food, right? You guys aren't old enough. You were born in the 80s, were you? Something that were. You guys would get organic food. We were getting preservative-free food. And so all the labels on all the foods said preservative-free. Well, what happened is they took out the chemical preservatives and they put in calcium. Calcium acts as a preservative. So we started throwing a ton of calcium into the dietary system in the United States, which is fine. It's good. But the problem is we were also taking a bunch of calcium supplements. So it was altogether, it was too much. So we have to remember that calcium is in a lot of our foods, and you can look at a label and see that pretty easily. We definitely don't want to get ever more than 1,500 milligrams a day when you add it up, and that includes diet and supplement. So if somebody is getting some in their diet, but you think, oh, you're not the best eater in the world, you do need a supplement, okay? That's cool, but we need to remember what's in the diet too. So we don't want to just automatically supplement 1,500 milligrams and then they go have a double dip for Brahms, because that would be a lot of calcium. You can do kind of a calcium calculator if you want. You can, and once you kind of know what foods have what, it's pretty easy to get an idea as patients tell you about their diet. Physical activity, we want to walk. Weight-bearing exercise does not mean lifting weights. It means walking on your bones. It means putting weight through your bones, okay? So 30 minutes a day, even 5 minutes at a time. If they walk around the house every time they go to the bathroom, they'll get 30 minutes in a day. If they take the cart around Walmart twice, they probably get 30 minutes in a day. Weight-bearing exercise is extremely important. Remember when I said that physical inactivity or not putting weight on your bones leads to bone loss? So the opposite is true. The more we put weight on our bones, the more bone we will build. And it's dose dependent. So if you have a go-getter patient and they want to walk 45 minutes or an hour, the more you do, the better it gets. So walk, walk, walk. You can also run, you can also jump rope, anything that puts weight on the bones. Elliptical, not the bike. The bike doesn't count because we're seated. The rower doesn't count because we're seated. Has to be putting weight through the bones. Balance and strength training, also really important. We used to say that only weight bearing helped bones, but it actually turns out that true strength training also builds bone. The stronger your muscles are, the better your bones will also be. It also helps fall. We want to do fall prevention. We do not want these people to fall because we already know that they're breakable, and the ultimate goal here is to prevent fracture, not just to fix their bones, but to prevent fracture. If they don't hit the ground, they're way less likely to break. We want them to stop smoking, of course, and stop drinking. And we want them to not be stupid. So climbing ladders, step stools, the kitchen chair, being a spider monkey, trying to get the crock pot down from the top shelf. Oh yeah. High heels when you're 85 years old, and you shouldn't wear high heels. It just shouldn't happen, right? Flip-flops. We've already talked about flip-flops. I won't go back there. I could, but I won't go back there. Physical activity. So we don't want to fall. And so if they have a history of falling, if they're weak, if they have gait problems, give them a walker, give them anything to keep them off the ground. If they have visual issues, send them to an ophthalmologist, send them to somebody to get their cataracts removed. Are they dehydrated? Is dementia an issue? We do not want them to hit the ground. So really important to address everything that would cause that. Again, and treating it is fixing all those problems we talked about. And we already did that. Exercise-wise, when they have osteoporosis, we want to avoid extreme range of motion. So extreme forward flexion, extreme extension, anything that jerks or twists, we want to stay very central. Core exercises are great. Proper posture is really important. We don't want to have them going and doing their first yoga class and having a compression fracture because they tried to, super extend. Just so when they tell them to do these things, we just have to, moderation is key. And that is more of the same. Balance training in the office, easy things to do, teach them to do it. Canes, walkers. These are balance braces that actually, if they have weak ankles, that will help keep them upright. They actually articulate a little bit, and they are really good. Their whole goal with a more balanced brace is to prevent falls. And then these fun things, right? Hip pads, which actually do reduce fracture risk. If you have somebody who's at really high fracture risk, they do fall a lot, they can wear hip pads. The other place to buy these is at Dick's during football season because these are very much like football pads and they work, and the compressive patients actually like the football pads well, and they do have shock absorbers in those areas. And so easy place to get them, and they look cooler. The FDA-approved drugs for osteoporosis. All right, back to medicine here. So the bisphosphonates, which you've probably heard of these as Fosamax, Actonil, Reclast, all of those. They are all generic now, so those are their generic names. Calcitonin, which is the nasal spray. Estrogens, so any hormone-related thing, and then the estrogen agonist, antagonist, so that's Evista or Loxapine. Remember I said parathyroid hormone would come back, and we have 2 drugs that are parathyroid hormone medications, and then a human monoclonal antibody, and that's Prolia or denosumab. And so there's our cycle again. All of our bone medicines work in this cycle somewhere. We're either stopping resorption, we're doing it very early before those little red cells come in to take up the bone, or we are proliferating the green cells. So we're either trying to stimulate the bone on the one end, or we're stopping it on the other. Keep in mind that if we stop it where the red cells are, where the osteoclasts are, we're also preventing the rest of that cycle from happening, okay? So anything we do in that cycle also stimulates the rest of it, or turns it off. So hormone replacement first. This is your Premarin, any estrogen-related thing, Duav, which is an estrogen-related product that is actually indicated for osteoporosis, any of your patches, all of those things, they slow bone turnover. So they don't stop it, but they slow the process of bone turnover. So that whole cycle, they just slow it down. So the thought behind that is if we're not taking up as much bone, then we won't lose it as fast. But we also don't put it down as fast, so there's a little bit of a downside there, but it does help a little bit. It will slow that process down. A lot of downside with hormone treatment, and this is not unlike any other reason that we might use hormones. So all the cardiovascular events, angina, stroke, embolism, bleeding, breast cancer, and MI, all of those things are risks with hormones. So we want to make sure this is a patient who can tolerate estrogen therapy. The anti-resorptive class, these also inhibit resorption. They are really strong inhibitors of resorption, so they are preventing those osteoclasts from doing anything. Those little red cells just never happen. Again, these were our early osteoporosis drugs, and if you prevent those osteoclasts from doing what they're supposed to do, we also prevent the whole rest of that cycle from happening, right? And so we are slowing it down. We're not fixing it, we're just slowing it down. They also stay in the bone for a really long time. So one of the first ones, Fosamax, actually has a half-life close to 10 years in the bone. We can still biopsy it and see it in the bone 10 years later. So really long skeletal retention. They do reduce some fracture risk. They do show a little bit of increase in bone mineral density, a little bit of fracture reduction in non-vertebral fractures, which is your hip fractures. They can have some serum calcium issues. Where we'll see an increase in serum calcium a little bit, so we have to watch that. And we don't want to use these in renally impaired patients, so any kidney patient we have to be careful with. Side effects of the bisphosphonates can actually include both hyper and hypocalcemia. We can just mess with that calcemic metabolic rate. Bone and joint pain, uveitis, which is an inflammatory condition in the eye. Renal dysfunction, again, we don't want to give it to somebody who has a lot of renal impairment. Atrial fib is something that FDA has been reviewing as kind of a recent thing. We think there may be a link with these medications and atrial fibrillation. Osteonecrosis of the jaw, which we're going to talk about a little bit more at length. This is the bone loss in the jaw. Somebody in your family may have talked to you about this in the past, or you've seen it or heard about it, ONJ we call that, as well as atypical subtrochanteric fractures. So two interesting side effects in this class of drugs that is designed to treat and prevent fracture. We're actually causing bone loss in the jaw, and we're increasing the risk of a special type of hip fracture. So those are some red flags with this class of drugs. Other side effects, they're difficult on the GI tract. Almost all of those are GI related. And then there's a flu-like condition that can happen also with them. Osteonecrosis, it's a condition of the lower mandible, the jaw. When it becomes exposed after some type of a dental surgery, not a tooth cleaning, but maybe a root canal or a crown thing, any kind of extraction, you're in much higher risk than of a process called osteonecrosis, where you will rapidly lose jawbone. And it's not something that we can really stop to any degree. You basically end up losing all your teeth, is what happens. And so it's rare, but when it happens, and we do see it. We do see it. It's not rare, so rare that we never see it. We do see it from time to time, and when it happens to you, it's a really crappy thing because we can't really fix it. So we have to be very careful with these medicines. We never use them in somebody who is getting ready for dental procedures or dental surgery. And if they are on them, we always take them off prior to undergoing, for a couple of months prior to undergoing that dental surgery.
Is this used for treatment of breast cancer in bone?
It is sometimes, yes.
Okay, so I think my grandma had the
It sometimes is, yep.
but it was up here.
It can also happen, it can happen anywhere, just commonly the lower mandible. Yep.
I didn't know if this was one.
Yep, it was one of them. There's quite a few, but yes, it was probably one of them. And when it happens to you, it sucks. So it's rare, but it happens. There is, again, the flu-like symptoms. It is basically extreme pain that happens. Body aches, pain all over, bone pain, and when it happens, and it can happen anytime. You might have been on Fosamax for 3 years, and then all of a sudden this happens. And the minute you come off of it, totally fine. I don't exactly know why it happens, but it is a debilitating treatment, or debilitating problem, until somebody figures out that it's the bisphosphonate that's doing it. And so we have to make sure, and again, most of these bisphosphonates are weekly or monthly, or sometimes yearly. So if you have a problem like this, we can't take it away very quickly. It has to run its course, which is unfortunate. You have to take it on an empty stomach, you have to stay upright, so there are some that are injectable, but the oral ones you have to make sure, basically we're trying to get it past your esophagus, down into your lower GI tract quickly, without any kind of regurgitation. We do not want it to sit in your esophagus, or we can have a lot of GI related issues with it. We always check your calcium and your kidney functions and your vitamin D levels before we give you these medicines. Calcitonin is the nasal spray, salmon calcitonin. It's fallen out of favor. It still is used sometimes with vertebral fractures. For some reason with vertebral fractures, it had a pain indication for compression fractures. So sometimes the pain guys will use it after a compression fracture. It doesn't work incredibly well, and it causes nosebleeds in everybody. So at some point they get nosebleeds from it, so we don't use it a whole lot. Parathyroid hormone. So there are two parathyroid hormone molecules. One is called Forteo, and it's branded. It's been out for 15 years. It could be generic if somebody could figure out how to make it cheaper, but haven't figured that out yet. Abaloparatide is the other one. Its branded name is Tymlos. They are both PTH 1 through 34. They are essentially the same molecule. The only difference being Tymlos has only been out for about a year. It is an unrefrigerated injectable. Teriparatide is a refrigerated injectable. So Tymlos' claim to fame is no refrigeration. The parathyroid hormone, remember when I said too much of it constantly, 24/7, causes bone loss. In a very pulsated format, with a portion of the molecule, the parathyroid hormone amino acid chain is 84 lengths long. the PTH molecule for these drugs is 1 through 34. So it's only the part that is stimulating bone. It doesn't do anything else that the parathyroid hormone does. It is very, very specific to bone. So, which is great because it makes these drugs have very few side effects because it's very specific to bone. It's not really doing anything. It's also very pulsated. So the half-life of these medicines, both of them, is about 3 to 4 hours. So it's in, does its thing, gets out. So not a lot of long-term issues with it, very specific to bone, and its job is to grow bone back. So its simple job is to grow bone back. And this is what orthopedic surgeons like. This is why I run a bone health clinic in an orthopedic surgery office, is because they want to grow bone back. They don't want to stop it from growing, like we do with all of the anti-resorptives. If you stop that whole cycle, what happens to healing? Doesn't happen, right? And in orthopedic surgery office, we're healing. We either did surgery or you broke or something happened, we're always healing. And so we want to stimulate healing, we want to stimulate the process. These drugs stimulate bone formation. So the little green cells on that cycle that we looked at, they're stimulating bone formation above and beyond homeostasis. So you end up with more bone than you had before. We give these to people who have fractured. We give them to people who have recently had surgery. We like for you to be postmenopausal. It is not a requirement, but we like that to happen. You generally are somebody who's high risk. High risk doesn't mean you've had a fracture. High risk can mean your mom and dad both had fractures. And we know that that is a huge risk factor for you to have a fracture. So instead of waiting for you to fracture, we would like to prevent that from happening. One of the risk factors for both of these, Forteo and Tymlos, is a boxed warning for osteosarcoma. Osteosarcoma is a bone tumor. It was seen in the original Forteo rat studies. So when rats were given 15 and 60 times the human dose of Forteo, some of those rats developed osteosarcoma. It was never seen in the chimpanzee or monkey studies at any dose, and it has never been seen in humans. There was a registry for a long time. It's been out for about 15 years. And so at this point, if we were going to see it, we really feel strongly that we would have seen it. They dropped the black box warning. It is now just a regular warning on both Forteo and Tymlos. Tymlos did not see it in their studies. They also didn't use rats. So we think that is generally why. This is not a forever treatment. No bone medicine should ever be a forever treatment. But this one is, both Tymlos and Forteo are 2-year treatments. We build bone for 2 years, and then we're done. The side effects of these medicines, not a lot. Headaches maybe, nausea sometimes. Very briefly, you can have a transient hypercalcemia when the medicine's first initiated. Not a lot of exciting side effects with it. Prolia is a very popular drug. You've probably heard of this one before. It's an every 6-month injectable. I should say that Tymlos and Forteo are both daily injectables. They're like little insulin pens. They're little daily injectables. Prolia is a every 6-month injectable. It is not a bisphosphonate, but it is an anti-resorptive. So when it is not in that class of anti-resorptives like Fosamax and Beniva and Actonil and those, but it does act in the same way. It just goes, it has the same method to its madness, but it acts in a little bit different way. It's a monoclonal human antibody. But its job is still to block the little osteoclasts from doing their thing. And so it is actually the strongest anti-resorptive that we have. It's given sub-Q twice a year. We try not to give it longer than 3 to 4 years. Otherwise, that risk of subtrochanteric hip fracture and the risk of osteonecrosis of the jaw start to really creep in. So it's pretty safe from 0 to 3 years and 4 years, but after that, that risk starts to creep up a little bit. So we don't give the anti-resorptives, and we don't give Prolia longer than about 3 to 5 years if we can help it. Too much suppression of bone. We also don't give Prolia to anybody who's getting ready to have joint surgery, who might have just fractured. We want to make sure that they are good and healed before we might ever use this medication, especially in an orthopedic setting, but even in a primary care office where people have little fractures and urgent care, you might splint them in your primary care office. You want to be very, very careful of giving somebody this medicine, or it can delay healing. Again, postmenopausal women is who this medicine is indicated for. And it is not self-administered, it is done in the office. Side effects with denosumab or Prolia are very similar to all of your anti-resorptives. It does have an effect on the immune system, however, where we do have a decreased immune response with it, it used to be used a lot with cancer-treated patients that are on chemo and other bone loss type medicines, and we would use this to stop that. But because of the immune response, or lack of immune response with it, we have kind of stopped that a little bit. It also had an increased risk of atypical femur fractures, just like the other ones, after 3 to 4 years. 0 to 3 years appears to not have that issue. After 3 to 5 years, then we have an issue. Combination therapy, so do we ever use all of these together? Sometimes. So studies show that if we use 2 anti-resorptives together, we get a little bit more fracture reduction. If we use an anti-resorptive and an anabolic, that's actually our best combination. The best fracture prevention that's ever occurred in any study was when they started the patients using teriparatide or Forteo, and it's that little daily injectable where we're building bone. And you start that first and you keep it going for about 6 months. You do continue it, but at the 6-month mark, you add Prolia on top, which is the strongest anti-resorptive. So now we're building bone, and we're stopping it from being resorbed all at the same time. Best fracture prevention we've ever seen in any study. Problem is, those are both 2 really expensive drugs, and there's an insurance company in the world who will pay for that. So it's a really expensive combination, but it works. We monitor these patients depending on their fracture history, depending on what medication they're on. We never want to go longer than about 2 years. In somebody who has osteoporosis, 1 to 2 years, or if they're being treated, no longer than 1 to 2 years. If they are not on medication, if their risk is very low, if they were normal or just mildly osteopenic, we don't want to go longer than 5 years. You can spread that interval out a little bit longer, but never more than 5 years. How long do we use bisphosphonates for? When I said earlier we never use these medications forever, Prolia specifically was 3 to 5 years. The same is true with Fosamax, or Beniva, or Actonil, or any of those bisphosphonates. We don't want to suppress that bone forever. You can suppress it for a little while and get away with it, but after a while it becomes brittle and more likely to fracture. And that's where those subtrochanteric hip fractures come in, is that we have made the bone brittle. So we go through a stage where we're helping it and then we're hindering it. So we have to be careful. There isn't a single bone medicine that I can tell you to put patients on that will fix it forever and keep them on it forever. It doesn't work that way, unfortunately. We're always doing a dance with your bone, trying to build it back, stop it from losing it, build it back some more, stop you from losing it again. It's always a dance. What else is coming? Interestingly, I had this slide up here last year, and we still don't have this drug. It's called an anti-sclerostin antibody. I was really sure we'd have it by now, actually. And this drug was an accident, as a lot of drugs actually are, when they figured out this anti-sclerostin antibody. The problem is this drug is being developed by the same company who makes Prolia, which is $1 billion a year drug. And this drug will probably compete with it. And the FDA sent it back for additional cardiovascular studies. There was one little marker in all of the data that went to them, and they said, well, we need some more studies. And so in order to go back and do studies, that costs millions and millions of dollars to do the studies. They have to decide, is it worth it to them from a financial standpoint to do the studies, to produce the drug that is then going to compete with the drug they have? So is it going to increase their market share or not? And the answer is probably not, because it's going to compete with Prolia. It doesn't replace any of the other drugs. It pretty much replaces Prolia, which is the drug they already own. And so they have not been super excited about going back and doing those studies and spending more money on a drug when they may not see it in the end. There has been some talk of another pharmaceutical company buying the molecule from them. That is probably the only way we will ever see an anti-sclerostin antibody potentially. So that again, it's still not a forever thing. It's an injectable. That's a monthly injectable. It is designed to build bone back, much like your Forteo and your Tymlos are, but in a little bit different way. We think it would probably be the best used after Forteo or Tymlos to continue to build that bone for another couple of years before using an anti-resorptive. But again, we don't have it, so who knows if we ever will. So when do we repeat the DEXA? We repeat it in 1 year if you started an anabolic medicine, something that builds bone back, like Tymlos or Forteo. So at 1 year, we need to measure how much bone we've built back. If you've had a new fracture, so if it's been 18 months since they've had their last DEXA, but they have a new fracture, or they have a first fracture, that's a good time to do another bone density test. Any patient that is high fracture risk, everybody in their family is fractured, they're on steroid medicine, high-dose steroid medicine, they should have a bone density every year. every 2 years if the patient is stable on medicine. So if they're on a Beniva or on a Prolia or something like that, they don't need one every year. If they're stable, every 2 years is fine. If it's an osteopenic patient with a moderate or low FRAQ score, so their risk of fracture is not very high, they don't need one every year either. They can get away with every 2 years. We repeat it in 3 years if the patient has had multiple stable DEXA scans over a period of 5 to 10 years. And if it's not changing, it's not getting worse, it's staying the same, they don't have any additional risk factors, we can get away with 3 years. And here are your most common, these are your fragility fractures that are diagnostic of osteoporosis. Your compression fracture, the distal 1/3 radius fracture, and that is a subtrochanteric hip fracture actually, not the femur neck fracture, but that fracture, that hip fracture there is the one that happens after you've been on an anti-resorptive medicine for too long and the bone becomes brittle. That's what happens there. If you need me, I'm happy to answer questions by email. Feel free to give me a shout on email. Sally knows how to get me too. So if you need me. Questions on anything related to the talk or not? Anything else?
I have a question.
Yes.
I heard that vitamin K2 was associated with increased
Maybe.
health, but I didn't know if you...
Maybe, we don't know yet.
Okay.
So there are some initial studies that looks pretty positive when it came to K2 and vitamin D and, you know, taking them together. And so the natural medicine companies jumped on that and promoted it. And it doesn't look like there's harm in it. That we've had some natural things in the past that have caused harm. And this doesn't appear to be the case, but there was a big study just released, a real big study, that actually doesn't look like it helps as much as we thought, but it still also didn't look like it had a downside. So I don't spend a lot of time telling patients to not take their K2, but I don't yet tell them to take it either, because I don't have enough evidence for that. Yeah.
Does physical therapy look different for a patient with osteoporosis and a fracture, or just?
It does, right, because we have to be careful, a little bit more careful. We've actually had patients in therapy that fractured because the therapist was too aggressive. Or the patient's bone was just so fragile. So if they had a rotator cuff surgery or something and they were being stretched and trying to get that range of motion back, we've had humerus fractures from that. So yes, it's important for therapists or home health or especially chiropractors. That happens. You don't want to send an osteoporotic patient to a chiropractor who's going to do aggressive manipulation on them. That's a great way to have a compression fracture or fracture of the spine, descents in the spine. So yes, you have to be careful. Yeah.
What made you leave PT for PA?
That's a great question. I did not go in to be a PT with the, I did it because I didn't know what I wanted to do when I grew up, and I needed to pick a graduate school really fast. And so my sister is a physical therapist, and my other sister is an occupational therapist, and I have another stepsister who's a speech pathologist. Wow. And so, so we were really big into the whole rehab thing. And so seemed like a good idea at the time when I was a college athlete, and so it seemed like a natural fit. And it was good for a while. I just met Sally and was like, I want to do what she does. What I do. So that's what happened, yes. But they're both good careers. It's not, it wasn't what I wanted to do forever. And now I've done primary care, which is great, and I think everybody should do primary care for a period of time. So
Like a residency.
You did primary care too, didn't you, for a while?
Yeah.
Yeah, it really is. And my heart and soul is still in primary care, it really is. And what I do is, right now is primary care, a lot of it, that's what osteoporosis really is. And I couldn't do what I did now if I hadn't spent 10 years in primary care learning the ins and outs of it. And being in private practice is a great way to learn about the business side of medicine. And being in private practice for 10 years in a small practice and having to run the practice and watch my accounts receivable and watch what insurances were doing and know how I was getting paid and who was paying me and what procedures were paying me and how I was getting paid led to what I do now, being over clinical operations at OSY, where I run the billing department and I run the desk and scheduling and DME and all of those things. It all is the business side of medicine. And if you have to understand the business side of medicine in order to function in medicine, it's amazing how many healthcare providers have no clue how they get paid. And if you don't know how you get paid or what you're getting paid for what you're doing, it makes it very, very difficult to be good and make a living at your job. Not that we're all doing it for the money, that's not true, but you do have to get paid for what you do. And unfortunately, we're really bad at that. Healthcare providers would do stuff for free. And it's why we're historically terrible business people. I mean, we really are, because you have that altruistic mind, and so you'll see anybody for free, and I'll just make this for free, or I won't charge very much for that, or I want to, and that's great. but you won't have practice if you do that for long, unfortunately. There is a business side to medicine, and it's really important that you understand it.